Hey guys, and welcome to our lecture on determining patient risk for complete heart block. My name is Clark Imus, and I'll be facilitating your online lecture today. Let's go ahead and get started. We have 5 objectives that we'll be covering throughout this chapter as we go through identifying patients at risk for a complete heart block. We'll define the 3 types of bifascicular blocks. That's two blocks in one. If you can't remember that, I'm going to get it stuck in your head before we're done. We'll also describe the clinical implications of a bifascicular block, the concerns we have for hemodynamic stability and the likelihood of them progressing into an arrhythmia. We'll also identify steps that can be taken to prepare for a patient who is at that high risk for a complete heart block. Again, we're talking about a patient that's going to end up into most likely a 3rd-degree heart block, or a block that's very high and very difficult for us to treat in the pre-hospital setting without pacing. And then we'll get into what practices we need to do in order to make sure that we're understanding how to determine if a patient is suffering from a bifascicular or trifascicular block. So a bifascicular block, when we look at a 12 lead, we're going to look at it the same way that we do any normal situation. We're going to go ahead and analyze this rhythm here, and I'm going to go ahead and get my pen out for us to do this. First lead we look at, again, is always going to be AVR. AVR is our first lead. We're going to do a comparison to see how that appears to lead 2. And again, we can see how AVR is globally negative compared to that of lead 2. So that shows us that our limb leads are in the proper location. Limb leads are on the limbs. The next leads we're going to look at are going to be V1, 2, 3, and 4 as we look to see if our precordial leads, our chest leads, are going to be on the right location as well too. Here we can see that we've got a little bit of an R wave here. Actually, V1 shows us an RSR prime wave here. We have a much higher R wave here, and again in 3, and then 4, 5, and 6 looks like maybe not the best placement on this 12 lead, but nonetheless we'll take it. So from there, we've made sure we've got the proper placement. Limb leads are on the limbs, precordial leads are on the chest in their proper location, and now we're ready to go ahead and to continue to start to look at where we're at. Now, as we take a look at this, again, the same thing we do every single time. We're going to start off by looking at leads 1, 2, and 3 for our axis deviation. Appears to me that lead 1 goes up. Appears to me lead 2 goes down. Appears to me that lead 3 goes down. We could use our rapid axis chart of up, down, down. Or if you're like me and you love the almighty wheel of axis, you'll more likely like this guy here. And this one we can see negative 83. So we know that 0 degrees is located here on our axis. This is lead 1. Negative 90 is located on the top, and positive 90 at the bottom. We have negative 1, not 1, but negative 40 here. So anywhere between 0 to negative 39 would be considered to be a physiological left axis deviation. But once it goes above that negative 39, in between negative 90 and negative 40, which where we are, this becomes a left axis deviation, or a LAD, and it is going to be physiologic, right? I'm sorry, not physiologic, pathologic. That's the big one. That's going to be pathological. There's conditions that are leading to this here. Get that out of there, Clark. That's not right. We're going to say that's going to be a pathological. There we are. All right, pathological. And that's important. So that's already one block. If we're looking with left axis deviation for a pathological section, we're going to be dealing with an anterior hemiblock. That's already one block within the conduction system. If I look at my PR interval, it's not greater than 100 and greater than 200, so I'm not going to be worrying about any type of first degree AV block. So I'm going to move on to my QR restoration. In this case, the QR restoration is greater than 120 milliseconds or greater than 0.10 seconds. What does that mean? Well, that means that I have criteria to assess for a bundle branch block. And here again, I'm going to use V1 for my criteria. I'm going to find my J point. Right there be about my J point. And I'm going to go up and over until I find that point of terminal deflection. This one moves up and to the right. Again, this is going to be an RSR prime complex. So because it is wide, greater than 120 milliseconds, and I have a positive terminal deflection upright, this becomes a right bundle branch block. So when I'm dealing with a right bundle branch block, an RBBB. That's one block of the conduction system, predominantly the right. We know that it only has one pathway, and one of the two pathways on the left, in this case the anterior fascicle, is blocked as well. Folks, that gives us two blocks in one. That's a bifascicular block. That's a real concern when it comes to our patients. Here's why. Anytime that you're dealing with the patient who has two or more blocks present, again, we're going to define that as a bifascicular block. But the key behind this is anytime that you have a patient who has a second degree type 2, a third degree heart block, a bifascicular block, a first degree plus a hemi block, or a first degree plus a bundle branch block, anytime that you say or imply that there are two blocks in one heart, that patient is at a high risk for a complete heart block, and arrhythmias are going to be present. And when we see those arrhythmias, we're going to treat them generally with medications. However, antiarrhythmics like lidocaine, procainamide are truly contraindicated. Let's take a look at this. This is the black label, if you will, or the caution label off of lidocaine. And again, it's the drug insert that's going to go with it, and it clearly states that the contraindications are. We know that lidocaine is contraindication with patients with known hypersensitivity to its use. That's common with any drug. But here we see intravenous injection is contraindicated with patients with Adams-Stokes syndrome, or, here's what I want to point out, severe degrees of sinoatrial, atrioventricular, or interventricular heart blocks. Contraindicated in. That's the key. That contraindication is going to be the big one that I want to make sure that we're paying very close attention to when it comes to that, because again, it's not uncommon for us to want to give lidocaine to a patient who may be in a pulse VTAC or a situation where they're showing excessive PVCs, all because they're at a risk for a complete heart block and their heart is irritated. But if I give a patient an antiarrhythmic medication and I already know that the ventricles are already blocked all the way, do you really think it's a good idea to give that antiarrhythmic, which is going to say to the ventricles, calm down, relax? Please relax and rest with all those horrible blocks in your system. Most likely, it's going to throw the patient into a third degree or some other form of a high complex heart block, and it's going to be requiring us to do more advanced procedures like pacing, sedation, and other things to get in front of this after we've tried to properly treat it. Another one that you want to make sure that you're using caution with is morphine. Morphine, in a lot of cases, especially situations dealing with myocardial death, STEMIs, things of that nature, morphine has a higher rate of death associated with it, higher mortality rate than that of other analgesics, for example, like fentanyl, if you're going to compare the two. Those that get morphine typically seem to die more than those that receive fentanyl. There's a whole lot more to study with that. But again, if you're concerned about the hemodynamic stability of a patient with multiple blocks in their heart, that bifascicular block patient, use caution with morphine as well. We also are going to take a look at what do we do? How do we prepare these patients for the things that we're going to get into, right? What do we prepare for when the patient has a bifascicular block and they're sitting on your cot? Well, the first thing you want to consider here is the stability, right? If you had a crystal ball and you can imagine if a patient was going to go into cardiac arrest, I would imagine there would be a number of things that you would do to prepare as that countdown got closer and closer, right? Make sure you have an IV, put your pads on, airway stuff is out, maybe the drug box is out, maybe meds are ready to go, whatever needs to happen so you're more prepared. Generally speaking, if you're caught off guard by an arrest in the back of the ambulance, it's never really a very smooth arrest, at least at first, or especially if you're transporting the patient, where you may have to stop and have somebody come back to help you begin the resuscitation efforts. We're talking about cases now before someone arrests, what to do to prepare for the high-risk patient. First, your pacer pads and your defibrillator pads, your combo pads, whatever you want to call them, they're going to expire and someone's going to throw them out. They cost money, but at the end of the day, if you don't use them, they cost as much money to throw out as they do to throw onto a patient. So when you deal with a patient who you believe is a high risk, a bifascicular, trifascicular patient, a patient who's showing a prolonged QRS complex, which is showing a very widened complex for our ventricles, I want to throw pads onto the patient because more than likely I may need to use them. And if I need to use them, early defibrillation is very successful If someone goes into an lethal arrhythmia, I can charge and shock within seconds versus trying to get my pads out, get them on my patient, start CPR, do the process of beginning an arrest, where if I'm prepared, I can easily begin to charge and defibrillate that patient immediately when that life-saving intervention is necessary. So there's where that's at, right? The other part of that is have your pads on and be prepared for sudden death or complete heart block. So if a patient goes all of a sudden from your sinus rhythm with a bifascicular block, like we've seen on our previous slide, all the way into a third-degree heart block, we can immediately start to pace the patient and be able to get capture with that. We can potentially do it fast enough where the patient may not even lose consciousness because we were able to get reperfusion, I shouldn't say reperfusion, but adequate perfusion back to the brain to keep them awake and conscious. Now, the other part of this is watch for hemodynamic compromise. Watch your blood pressure, watch your pulse rate, watch your end tidal. Those are going to be good indicating vital signs for you to let you know if your patient is becoming more or less stable. The other indicating clue for this is to use the measurement of your QRS complexes. A normal QRS complex typically should be less than 0.12 seconds, 0.12 seconds, or less than 120 milliseconds, right? If you're dealing with a bundle branch block, it's typically going to be greater than 120 milliseconds. But if it gets up to the point where it's now at 170 or higher, now we're knowing that those ventricles are not able to fully contract effectively. We're no longer able to get the adequate contraction of the ventricles to get adequate perfusion going with those as well too. So it's a good indicator. If I have a patient who's got multiple blocks, who shows a widened QRS complex that's well beyond the 120 millisecond criteria for a bundled branch block, they've got that secondary block within the atriums, AV, SA, or in those bundle branches, then that patient is a big risk for a complete heart block or an arrest. Again, be prepared. Anticipating those problems will make it that much smoother for you to be able to tackle them effectively and hopefully provide your patient with a better outcome. Now again, if you look at this EKG, again, you're going to see here that we have an anterior hemiblock and we have our right bundle branch block. These two guys alone indicate right off the bat that our patient is at a high risk for a complete heart block. So using medications like lidocaine or procainamide or morphine, I should use extreme caution when I'm using those. And again, remember that procainamide and lidocaine, according to the black label, to the label box warning, it is contraindicated in any SA, any AV, interventricular node blockages, as we can see. Again, just to quickly give you an overview of what we have looked at here with our EKG. Again, I'm going to look to see AVR is globally negative. I'm going to again compare that down to my lead 2. I'm going to take a look at my axis deviation, in this case 83. That's again going to fall within the circle here, the wheel of axis. Again, here's that negative 40 and the negative 90. Clearly it's going to fall up here. Left axis deviation, pathological. Pathological creates an anterior hemiblock. Come over to V1, then to check out my bundle branch criteria. Here I can see an RSR complex, or an RSR prime. R is referring to the second prime is referring to the second R wave. We don't actually have a QRS wave here. And again, I can find that J point. Here's that J point. I can point out a couple different J points. It doesn't matter what lead I'm in, they all have J points, right? They're all going to fall somewhere like around in here. You can use those to kind of determine where they're at. In V1, though, we're going to use it to find that point of terminal deflection. And we're going to say if I'm driving my car, I'm going to flip my turn signal up to the right, and I'm going to take a right-hand turn. Again, where it points up right, that's a right-hand, or right-hand, that's a right bundle branch block. Again, this is going to be some really important criteria for you to take a look at as you get into this. Now here's another example of a posterior hemiblock along with a right bundle branch block. Again, if we take a look at our primary criteria of our R axis, so you can see R and R, 140, so here's my wheel of axis. Again, I have my 0, I have my negative 40, right? I got my positive 90, and I got a positive 180 back here, depending on which way you go around. This way will be positive, this way will be negative. But at 140, at 90s here, positive 180s here, I'm looking somewhere in here. This, folks, is right axis deviation. Rad ain't rad, folks. And rad is going to refer to a posterior hemiblock automatically. Again, on this one, I don't like the ups and downs. I can't really see it here, but if we were to try to guess this, I don't know, maybe down kind of in the middle, kind of up. Again, I'm a big proponent of using your R-axis numbers to help you be able to plot where that is so you can have a better idea. So that's our posterior hemiblock. So that's one block that we have already within our left ventricle. And now we're going to look at the right bundle branch. Remember, the right side, the right ventricle only has that one pathway, so it's concerning to us. Here again, I'm going to go to V1. I'm going to go ahead and take a look and see where my QRS complexes are. In this case, I'm going to say, okay, I've got a little bit of a complex here. Looks like I actually have a PVC right here. I probably shouldn't be counting that guy. I'm going to look for some commonalities, so these ones look better. Here I'm going to find my J point right about here. And I'm going to go up and find that point of terminal deflection. Again, it moves upright, driving my car, flip my switch up, turn right, or upright as you stand. That's a right bundle branch block. So here again are two blocks in one. Another example of a bifascicular block. But wait, folks, there's more. So when we're taking a look at our bifascicular blocks, here again you can see a primary example. First, again, as we would go through, we can see AVR is globally negative and compared to that of lead 2. We also can see right away that our QRS, or our primary PR interval, is again less than 200. So we know that we're not dealing with a first degree heart block. If it was greater than 200 milliseconds or greater than 0.20 seconds, we would consider that PRI to be prolonged and likely to have a first degree heart block. Not in this case, though. The next one that we're going to look at is our QRS complex. In this case, it is greater than 120 milliseconds, so therefore it is considered to be wide, which means our bundle branch criteria for V1 will be utilized. Before we jump into that, we're going to take a look at our axis deviation. This one appears to go down, up, I would guess. I'm going to take a look at my axis, my R-axis, draw my almighty wheel of axis. Come on over. Here's my 0, here's my negative 40, here's my positive 90, and then again over here is going to be my negative 180. So my 147 is going to be somewhere in here. That's going to be an example of RAD, right axis deviation. RAD is a posterior hemiblock, so it's automatically one block I have so far in my left ventricle. Let's take a look at V1. I see an RSR complex here. Again, here's my J point going up to the point of terminal deflection. It points up right. I'm driving my car. I flip my turn signal up. I can turn right. That creates a right bundle branch block. Again, this is a prime example of what you're looking at for a bifascicular block. We have a posterior hemiblock and a right bundle branch block. That's two blocks in one. Dangerously sick heart. Again, as we continue to go on. Now, let's take a look at another example here. This is truly just a left bundle branch block. If you remember from our previous lectures, I'm going to draw the AV node. This is the bundle of his. Move up into our right bundle branch. And then we have our anterior and our posterior fascicles that are going to be on the left ventricle. So again, right ventricle, left ventricle. In this case, if I'm dealing with a block high on the left side, high on that left bundle branch, then I'm going to immediately have a left bundle branch block, but that left bundle branch block contains two blocks in one, a block of the anterior fascicle and a block of the posterior fascicle. So that gives us two blocks in one. That is an example of a left bundle branch block, which naturally is a bifascicular block. So if we were dealing with a situation where we had more than one block, it could be a bundle branch block on the left all on its own, or it could be a posterior hemiblock and a right bundle branch block, or a anterior hemiblock and a right bundle branch block. Those are both examples of bifascicular blocks. So let's take a look at this one and go ahead and do our criteria. Right off the bat, you can see here AVR is globally negative in comparison to lead 2. I'm going to again ensure that I have proper R wave progression here with my V leads. I'm going to go ahead and take a look at my PR interval. My PR interval is not greater than 200, so I don't have a first degree. My QRS duration is greater than 120. And my concern here is, look how high it is. It's 146. If this were to get to be greater than 170, I'm going to be super concerned if it gets greater than 170. There will most likely be hemodynamically unstable and require the need for pacer pads and additional monitoring. We're not quite there yet with this patient, so let's keep taking a look. Our axis is going to be 19. Take a look at our almighty wheel of axis. Here's my crosshairs. Here's my 0. Here's my negative 40. And then down here is going to be my positive 90. And we're at wonderful 19 here. And again, this is going to fall into the normal section. So I don't see any type of atrioventricular block or AV block. I shouldn't say AV block. I don't see any type of anterior or posterior hemi blocks. If I take a look at my leads here, I see lead 1 goes up, lead 2 goes up, and it looks like lead 3 goes down. Again, that's going to be considered to be still fall within the normal range. Because it's wide, I'm going to go over to V1, and I'm going to take a look at my left bundle branch criteria, find my J point, down to my point of terminal deflection. In this case, it points down to the left. And when it's left or low, that is a left bundle branch block. And remember, automatically, a left bundle branch block is blocking both the anterior and the posterior fascicles. That's how you're getting a bifascicular block. Again, another example you can see here of a bifascicular block. In this case, negative 79. And our wheel of axis, again, negative 79 is going to fall right up in here. So here's our negative 40. This is going to be our negative 90. And somewhere right up in here will be our negative 79. That's going to be left axis deviation. So it'll be our LAD, but it's going to be pathological. Pathological is the concern here, right? Pathological meaning that there's an actual block. So pathological left axis deviation creates an anterior hemiblock, right? So there's our first block right off the bat. Our PR interval, we know for this one, it's not present. Our QRS duration, man, look how long it is here. QRS duration is definitely greater than 120, and we are verging on that if it's going to be greater than 170. Now we're super concerned about hemodynamic stability, and we're getting much closer to that. Again, this is an indication where I'm going to go ahead and probably put my pads on my patient, but I got more to look at. Because it's a wide QRS complex, I'm going to go ahead and go right to V1. Find my J point right about here. Go up and over to the point, don't know what happened there, but go up to the point of terminal deflection, and you can see that it is going to be upright. So now we have a right bundle branch block, an RBBB, and we have a an anterior hemiblock. That's two blocks in one. And my concern is going to go very high because of that 164. That makes such a big difference when it comes down to it. I can't tell you enough that when I think of this number here, the closer it gets to 170, the closer you should be concerned, the more you should be concerned about your patient becoming hemodynamically unstable. Again, another example of a bifascicular block here. I'm going to go a little bit faster. This case, we're going to see our positive 145. So our positive 145 is actually in the almighty wheel of axis. It's going to put us over in the right axis deviation. Right axis deviation ain't right. Right ain't right. And we're going to call that a posterior hemiblock. In addition to that, I know right away, look at my QRS duration here. Holy cow. Greater than 170. We're at 216. This patient is very likely to be hemodynamically unstable and very likely to progress into a complete heart block or other type of arrhythmia. Again, if I take a look at my V1 criteria here, you can again see the RSR prime, but look how wide that complex is. Man, that's not pretty at all. That's going to cause us some problems. However, we know that it's going to be a right bundle branch block. Here be our J point, and our point of terminal deflection goes up to the top, creating a right bundle branch block. So, again, in this case, posterior hemiblock, right bundle branch block, that's two blocks in one. But wait, still, folks, there is more. Let's add in that first degree hemiblock and take a look and see what we have here. Right off the bat, folks, as we do our normal aspects for interpretation, the first thing I'm going to look for here is PRI. PRI, my gosh, look how long that is. If it's greater than 200, it automatically equals a first degree AV block. So there's one block we already have right off the bat. We can determine that in lead 2. Now, the next thing that we're going to take a look at is going to be to make sure where we fall with the rest of our criteria. So again, I'm going to use my criteria for axis deviation, Negative 46, here's my wheel, right? Negative 40 is right here, and that's what separates our physiologic left axis from our pathologic left axis. There's our 46. That automatically is going to give me left axis deviation, which equals an anterior hemiblock. So boom, now I have a first degree arc block and I have a hemiblock, an anterior hemiblock. Q restoration. Q restoration is not greater than 120 milliseconds, so I don't need to worry about that. This criteria alone is going to give me enough. This is another example of a bifascicular block. You got yourself a first degree and a hemiblock. That's two blocks in one. That's a bifascicular block. The concern is there that your patient will become hemodynamically unstable or go into a third degree or complete heart block. Again, one more for you here. PR axis in this one is going to be 35. It's going to put us in a normal axis. Again, leads 1, 2, and 3 appear to point up. If I look at V1, V1 again appears to be wide with a Q restoration of 136 milliseconds. And my PRI, my actual interval here appears to be within normal limits. It's less than 200. This is my first and primary concern right here. Again, I can see that my J point exists as such. Up to the right, creates an up arrow. Driving my car, flip my turn signal up, I can turn right. That creates a right bundle branch block. So my questions for you, if we had normal axis, and we have a normal PRI, and we have a Q restoration that's long, and all we see is that abnormality in the V1, is this a bifascicular block? The answer is no, it is not a bifascicular block. Why? I have no blocks within my axis, and I have only a right bundle branch block. Again, if I go through here, let me draw one more time for you. I'm going to go ahead and draw my lower half. So this is going to be my AV node. Down in my bundle of his right bundle branch is right here. And then this guy's going to go up that way. Oops, kind of got a little crazy. This is my left bundle branch. And then I have an anterior and a posterior fascicle. And again, these guys, and I may have these backwards, folks. I can't remember off the top of my head right off as I'm saying this. But nonetheless, if I only block here on the right-hand side, there's only one thing to block. But if I block on the left-hand side, now depending on the location of those blocks, whether it's posterior, anterior, or a left bundle branch block, that becomes a concern. But a right bundle branch block on its own is not a bifascicular block. Here's another example, though, that would be a bifascicular block. Again, negative 66 on the almighty wheel of axis. Just kind of draw some crosshairs here. Negative 66 is going to be up in here somewhere. That's left axis deviation. That creates an anterior hemiblock. I'm going to take a look and see. PR interval, don't have any, so I don't have to worry about that. Q restoration, it is Y, greater than 120 milliseconds. So I now know that I'm going to have criteria for a bundle branch. Take a look at V1 as my lead. Find my J point, up and down. This is considered to be a left bundle branch block. So here, folks, we said we have an anterior hemiblock and we have a left bundle branch block. This is truly a bifascicular block. Why? Because we're having a block of both pathways in the left ventricle. Both the anterior pathway and the posterior pathway are blocked. Why? Probably because the left bundle branch block is very high on the branches coming off the bundle of his. It hasn't actually just applied to one fascicle branch or another. Again, another example that you can see here. In this case, 132. We're going to be in the axis here of right axis deviation. Right axis deviation creates a posterior hemiblock. We know the Q restoration is wide. There's no PR interval that's noted here. But up here, boom, now we can go ahead and we can see this is an upright. So here we have a right bundle branch. If I can draw that correctly. Right bundle branch block, an RBBB, and we have a posterior hemiblock. This, again, is a prime example of two blocks. We have the posterior fascicle blocked, and we have the right bundle branch itself blocked. Another one here for you. Again, negative 85. You're going to see that negative 85 is going to fall into a pathological left axis deviation. Again, here's that. Negative 40s over here. Negative 85 is pretty high here. That's going to give us left axis deviation. That's going to give us a example of a pathological left axis. And then we can also go ahead and take a look at our QR restoration. QR restoration is pretty long. Again, it's at 164. At 170, I'm really concerned about my hemodynamics. What's my blood pressure? What's my vital signs? What's my capnography for my patient? I'm going to pay close attention to this. So again, I've got that anterior hemiblock, and I'm going to find my bundle branch over here. I'm going to go up and over. It's going to be an upright. So this creates a right bundle branch block along with a anterior hemiblock. That creates two blocks. One block on the right branch and one block on of the two branches on the left. We'll do one final one here as we wrap up. Again, as you can see here, I'm going to first go ahead and I'm going to start out by determining what my PR interval is. PR interval is going to be okay. It's not greater than 200, so I'm not worried about a first degree. QR restoration is greater than 120, and it's very close to the 170 milliseconds. That's going to show signs of hemodynamic instability, paying close attention to my blood pressure, my EKG, my capnography. I'm also going to take a look at my axis. In this case, I have a positive 1 for my axis. That's going to give me a normal axis there. But again, with my criteria being met for a widened QRS, I'm going to head to V1, find my J point, go down to my point of terminal deflection, goes down low. Down low creates a left bundle branch block. And we know that a left bundle branch block is automatically two blocks in one. That does it tell us? It tells us that both the anterior and the posterior fascicle are blocked. This again is a prime example of a bifascicular block. So I hope that this was helpful for you. As you can see, axis deviation, bundle branch blocks, and patient assessment all are starting to converge together to help you prepare to provide your patient with the best pre-hospital care that you can. I hope that this was helpful for you, and we'll catch you on the next one. Thanks, everybody.